audible.
Yes.
Okay. Thank you very much. Thanks, Dr. Siddharth, for giving me this opportunity. I'm going to talk about cataract surgery in patients with AMD. I'm going to finish fast because everybody's in a hurry. Anyways, the challenges that we normally face is unanswered questions which are there in AMD. What is the risk of progression after cataract surgery? Will there be any benefit after cataract surgery? When should I operate? And again, the grading of cataract and AMD in relation to the visual function and manage the visual prognosis and the patient's outcome. This is actually very important. We all know that the cataract surgery causes inflammation, number one, intraocular pressure fluctuation changes, which causes changes inside the eye, and it causes change in the blood retinal barrier as such. So, and it can actually cause decompensation of the fragile choroidal vessels that have taken place due to ARMD, and it can also cause further leakage and hemorrhage. So if you look at the articles that show that, excuse me please, yeah, which shows that cataract surgery is a risk factor for AMD, there are 3 big articles which are studied 7,664 patients in the Beverdam study, which is quite old, in 1998, Blue Mountain study again in 1998, and Rotterdam study, which is in 2008. All of them had shown that there is progression of AMD after cataract surgery. In the first study, Beverdam study, there has been an increase in incidence by 11.5% and progression by 3.8% in a huge population. And the Blue Mountain study showed incidence of AMD in 7.6% of pseudophakic and aphakic patients, and as compared to 2.1% in phakic patients. And Rotterdam study also has shown there's an increased risk of geographical atrophy. But these studies were done during the most, when SICS is to be the surgery of choice for cataract surgery, and probably injection anti-VEGF was not available. Then came the studies which showed that cataract surgery is not a risk factor for AMD, and these include age-related eye disease study, which came out in 2006, which showed that there's little evidence of progression to wet AMD or geographical atrophy after cataract surgery. And then the age-related eye disease studies 2, which studies 1232 patients in 2012, which shows that there is actually an improvement in vision in patients with AMD if they're properly treated, and they've shown that they're plus 10.4 letters improvement after cataract surgery. So a review analysis of lot of studies that took place, and it had come out in 2014, has shown that cataract surgery actually benefits the patient in AMD. And the 2 very well-known study, Anchor and Marina trials, have also shown that cataract surgery appeared to be safe and beneficial for all eyes with AMD, including ranibizumab-treated eyes with neovascular AMD. But, a big but, a study, it's a meta-analysis which came out in September 2020, last year, September, from China. It's a big study where they studied more than 3,500 patients, and they have shown that Asians are more likely to develop AMD after surgery, and Asians and Caucasians differ in AMD genetic structure. So we need to understand this, and they have shown that there is a positive correlation between cataract surgery and progression of AMD. Now coming to the IOL selection, as we all know, AMD affects visual acuity and contrast sensitivity, and hence we need an IOL which has got a brighter light to retina, lesser glare, and lower light scatter, and hence aspheric, monofocal, and toric lenses are accepted because they provide better contrast and less glare. Multifocal IOLs are not recommended because they are known to cause reduced contrast sensitivity, but a big question mark comes whether we should use a blue blocking intraocular lens or not, because the benefits they give are they reduce the transmission of 430 nanometer light, which is a harmful light, to by 50%, and reduces the cell death by 80% as per the study Sparrows and colleagues in JCRS 2004. It also causes reduction in geographical atrophy, and that is also came out in a study in 2015. But the problem is patients with AMD are already suffering from reduced scotopic sensitivity, and these lenses are known to reduce the scotopic sensitivity by 14 to 21% as per this particular study. And rod cell population and sensitivity reduce with age and also AMD, and these patients have worst contrast sensitivity and blue yellow foveal sensitivity. So we really actually do not know whether to use these lenses in patients with AMD or not. Now, coming to a few words about the visual prosthetic IOL devices that are used. This implantable miniature telescope, which was approved by FDA in 2010, it is for monoocular implantation. They enlarge the retinal image by 2 to 3 times. They are good. Only problem is they are too thick like this, and they lie so close to cornea. There's enough chances that the patient might get corneal endothelial loss. Another lens which was very popular, which came out from Optolite Vision in Israel, it's basically a mirror telescope which can be implanted even in pseudophakic eyes as a piggyback lens, and they produce retinal enlargement, and they are actually very good because they cause improvement in vision by about 20 to 30%. Then there's another IOL VIP lens, which is a dual concept wherein you put in a high minus lens in the bag and a high plus convex lens in the anterior chamber. And this also gives a magnification of 2 to 3 times. This is how it looks. There are two lenses. It can be done in a single surgery, but again, the risk of endothelial damage because of the anteriorly placed ACIOL. This particular lens, IOL AMD lenses, this is a Galilean telescopic lenses, which is basically a prismatic lens, which deviates the light that is falling into the retina, is has become popular, and it's also available in India nowadays. And they can cause an increase in best corrected visual acuity by 67% and near vision by 50% if the patient is chosen properly. This is the Indian version of this lens. I've got an experience of using these lenses in 3-4 patients till now. What actually it does is, instead of focusing the light onto the fovea, it takes up a point which is 7 to 10 degrees of the fovea. These are called preferential retinal locus, and hence if the patient has got a healthy retina at an axis of 7 to 10 degrees, patient is going to get a better vision. This is a patient. KC Das is basically a cultivator. That's my first this sort of AMD lens implanted. As you can see, the right eye has got a large geographical atrophy, and hence nothing could help this particular patient. In the left eye, the atrophy is confined to the center, and this patient had a preoperative vision of 6/36. Cataract was not that much, but still I ventured to put in this particular lens. And as you can see, the distant vision improved from 6/636 to 6/12, and the near vision improved from N36 to N/8 corrected, and the patient was actually very happy. And if we undercorrect these eyes with +3 diopter and put in an extra spec of +3 diopter for reading, this patient will get a extra magnification of 1.5 to 2 times. That's again beneficial for the patient. This is another patient. It's not a case of ARMD, so I'm not discussing. So coming to the timing of surgery in relation to VEGF therapy, there's again a bit of controversy. We all know that the aqueous half-life of bevacizumab is 9.8 days within the eye. Ranibizumab is 2 hours within the eye. Brolucizumab is 4.5 days. And hence, if we inject these agents during operation, there is a risk of dilution of the medication. It can affect wound healing and even can cause wound dehiscence. it can increase the inflammatory response. So as per the study which came out in 2011, anti-VEGF should be given 1 to 2 weeks before phaco, and that is safe and effective in cases of AMD. So to conclude, the key points are, it's a tricky situation and it needs additional consideration. Good preoperative examination and assessment is pivotal. Extra preoperative chair time with the patient and party is required. We need to aim at least traumatic surgery and a good perioperative medication, and plan and discussion about the disease and proper timing and course of anti-VEGF injection that might be required are to be properly discussed. Thank you very much. Thank you for the patient hearing.
Thank you.